We present a case of DALK associated with cataract surgery. Instead of a big bubble, we perform a technique using a mini microbubble to reach Descemet's membrane layer. Patient is a 48-years-old male, diabetic with cataract in his right eye, and keratoconus treated with intercorneal ring segments in left eye plus a central scar. Best corrected vision is 0.1 right eye, 0.05 left eye. In his right eye, he has diabetic retinopathy treated with PRP, but in his left eye, cataract doesn't allow us to evaluate the foveal area. In OCT, we detected macular edema in both eyes, which was our priority in the moment of diagnosis. Once it's under control with anti-VEGF injections, we start planning PHaco DALK procedure. Anterior segment OCT shows a remnant stroma of 200 microns under the rings, so that's the depth we will trephine to ensure a safe PHaco surgery and avoid perforations which would complicate it. Once superficial stroma is delaminated, there is still a ring inside it. Sometimes it's easy to remove just pulling, but in this case we use crescent knife to open the fibrotic stroma surrounding the ring.
We make a dome with HPMC over the stroma to improve visibility and proceed to inject trypan blue to perform a correct capsular rhexis. This is a key moment in the surgery which can change completely the procedure. If we don't get a proper capsular rhexis, it will be very difficult to avoid tears in anterior or posterior capsule and lens dislocation, due to the pressure changes during phaco emulsification. Once we performed phaco, we proceed to remove the cortex and we implant a monofocal lens. In cases like this, IOL power calculation is intrinsically less predictable. So we calculate the lens power according to axial length and standard keratometry. I don't close the surgical wound to be able to manage intraocular pressure. The softer the eye, the less risk of converting to penetrating keratoplasty. I like to fill the anterior chamber with air, keeping the eye soft. Removing HPMC remnants from the dome will help to locate the place where the ring was placed. As we know, there is at least 200 microns in the stroma, so we use this area to inject the air with a 30G needle beveled down. As soon as we see the bubble progressing through the periphery, we stop injecting, because we don't want to reach the incision axis, as there is a break in Descemet's membrane there caused by phaco. This mini microbubble reached the plane we were looking for, so we have to take advantage of it. The trick is to cut the stroma, always with a very soft eye to avoid puncturing the deepest layer, and dissect the periphery with a blunt instrument so that if there is a perforation, it doesn't occur open sky. Dissect and cut carefully the stroma until you find a leakage area, of course in the incision axis. Once you are there, stop cutting. In these cases, intraoperative OCT is very useful to check periphery. We finish suturing the graft, and this is the image after 24 hours. Clear graft. 1 week later, we can evaluate retina with the slit lamp. Key moments in this surgery are: first, performing a cornea delamination enough to see details of the anterior chamber and to get rid of the cornea scar without risking the anterior chamber integrity. Second, perform a continuous central capsulorhexis. Third, achieve Descemet's membrane layer with a small bubble. Fourth, dissect from center to periphery 2. Fifth, avoid conflict areas.